I think we're all familiar with Zoom after a year and a half now, but all of you are muted except for me and our esteemed guest. But you are free to submit questions, like I said earlier, at any time in the Q&A box. And if you see a question that you also want to ask or you would like to eagerly have answered, please let us know by liking the question, thumbs up, and that will put it to the top so that we can focus on that question and make sure we get to it first. The more likes, the more questions that we can get to. If you have any technical difficulties, please put them in the chat box. My colleague Sarah is standing on by to help you with anything that you may have. If you can't hear or see, or if you mistakenly put your question in the chat, she will direct you to put in the QA. Questions are welcome at any time throughout. And we have a great agenda this afternoon. The welcome says Jennifer Kovich-Bordnick, our CEO, but today I'm her stand-in. Unfortunately, she couldn't join us this afternoon, but that doesn't mean we're not gonna have a great program, we're not gonna have a great time, because we still got some great material planned for you. We've got some experts who are really gonna talk about this, the foundation of this act, and give us an overview and explain it. What does it actually mean? There's always an act and there are 10,000 pieces to an act, but what does it really mean? And what are the things that we should be thinking about? And most importantly, I think they're gonna answer the question, what's keeping them up at night? And we wanna know what's keeping you up at night about this. And then we'll talk about how health IT leaders are approaching this. What are the things they're thinking about long-term? What are the pressures they're experiencing? What are the impacts going down the road and down the pike as we look 6 months, 1 year past inaction of this act? And then we'll have a nice discussion with our panel. And at that time, we will address the questions that you submitted either during registration or during into our Q&A box. And then we'll have a nice round robin of closing remarks. But before we do that, I want to show this lovely picture of our moderator and our speakers. That is Jane Kovich-Bordnick, who I said could not be here, just plug my face in there. We have Josh Roll, he's the Government Relations Manager from the American Heart Association. We have Matthew Albright, who's the Chief Legislative Affairs Officer, from Zelis. We have Ruby Raley, who is the VP of Healthcare at Axway. And we're intending to also have one of our other speakers, Eric Holmberg, who unfortunately could not join us today as well. I've introduced you to the speakers. I want you to learn more about EHI. Welcome to EHI. If this is your first webinar with us, I want to say welcome. If this is not your first, I'll say welcome back. EHI is a member-driven organization. We've been around for 20+ years, and our strength and our mission is really healthcare transformation by bringing together multi-stakeholder constituency. We've been focusing a lot on COVID-19 and diversity and innovation, and you'll find that we talk about this a lot in the various events that we host. For more information about us, go to our website, ehidc.org. These are our members. If you don't see your logo there, that just means we haven't engaged with you yet, but we would like to. If you'd like more information about how to become a member of EHI and what that actually entails, you can email me. I will put my email in the chat box later so you can get more information. I want to say thank you to all the members that do support us. As a small nonprofit, we rely on our members to support our mission and to support our programs, such as the one that you're watching. And also, this is how we share ideas and we talk about emerging trends and challenges through all of these stakeholders in healthcare. We have 4 primary focus areas, SDOH, social determinants of health. We focus a lot on health data and privacy, virtual care, which has become really an emerging topic over the past year. And then moving forward, COVID-19 best practices and innovation. I think there's no shortage of any conversation we can have around any of these topics. And we release reports, we have webinars, we have executive roundtables, and we also release policy papers and one-pagers. All of these documents are on our website. Feel free to check them out. You can look at our old webinars. You can read some of our past materials. Everything is free to the public, so please feel free. And this is some of the recent reports that we've published. We actually have another 2 reports that will be coming out soon. One on best practices in value-based care, and the other on, we just did a roundtable yesterday, actually, I can't remember what it was, on cybersecurity. So that report will be coming out soon, in addition to the reports that you see listed here. Again, feel free to check them out. And we have a huge event coming up in November. It's our first Digital Health Equity Summit. I invite all of you to register. It is free to attend. Again, you can find the information on our website. It's 2 days. It's a conversation where we'll be talking about the technologies and innovation and policies that impact health equity, and what are the gaps and challenges that remain for healthcare stakeholders like you and I to address these challenges. And last but not least, I would like to thank our sponsor, Axway. As a small but not mighty nonprofit, we couldn't do these things without the support of our sponsors. And so we do want to thank and recognize Axway for their support. And again, thank you. And with that, I would like to turn it over to, I believe Matthew is starting, and we'll talk about what's keeping you up at night. What should we all be concerned about?
So Juane, if you didn't have a list of things to keep you up at night here, we thought we'd provide it for the participants here. Thank you, Juane, and thank you, Axway and EHI, for hosting this. I think it's going to be an exciting discussion. So this is what we have for January 1st, 2022. And what we've kind of done here is, because we're talking mostly about transparency, we've listed both the requirements that have come out of the Transparency and Coverage Rule. It's the Healthcare Transparency and Coverage Rule that was published in November of last year. That was a regulation. And then the No Surprises Act, as many of you know, was passed as part of the Consolidated Appropriations Act on December 27th. And that has an effective date. Both that and the Transparency and Coverage Acts have effective dates of January 1st of this coming year, 2022. So if you think about all the requirements in those two sets of rules, right, you've got two categories of requirements. And if you look at the right, those are the requirements that really apply to kind of a small segment of claims today. And these are the out-of-network claims. And this is really the title of the bill, the No Surprises Act. So these are a set of rules that and a law that surrounds a set of claims that where members, where patients are traditionally balance billed. That is, they're stuck with a bill because the provider that gave them care was unknowingly to them, at least at the time they entered the hospital, was out of network. And so they end up with a larger bill. So that's what Congress meant to do really with the No Surprises Act, is this segment of bills protect members from emergencies, from out-of-network providers who are providing care in network facilities. So members or patients who go into those facilities are surprised because they didn't know that their in-network facility had an out-of-network provider. And then air ambulance, all air ambulance transport. So members are protected. That's the right. On the left, however, and maybe this is one of the surprises of the No Surprises Act, is the No Surprises Act added quite a few transparency requirements to the already Transparency and Coverage Rule. And if you're coming from the provider sector, the hospital transparency rule, which requires transparency about pricing on hospital websites. So there's the two categories. I think we're going to focus mostly on the left. But before we leave this slide, I'd like to turn to Josh Roll with the American Heart Association and kind of get his viewpoint on how he feels about those surprise balance billing protections. If he feels like those surprise balance billing protections are really going to help the consumer, or there are loopholes that we should be aware of. So Josh, what are your feelings on the right-hand column there, those protections?
Yeah, so given the outsized impact of surprise bills on cardiovascular and stroke patients, we've spent years urging policymakers, in conjunction with public and private stakeholders, to take a multifaceted approach to comprehensively address the issue of surprise medical bills. And so obviously, then finally, after 2 years of hearings, markups, campaign ads, and negotiation, Congress included the No Surprises Act and the omnibus spending bill that was passed and signed into law in December 2020. Overall, we are very pleased with these requirements, and once they go into effect, they will truly provide patients with a significant peace of mind. And I honestly think they truly represent a monumental leap forward for all of the 135 million patients and consumers, covered under this law. It's just the protections, again, I can't emphasize enough how truly historic they are. Patients are protected from surprise medical bills that could arise from out-of-network emergency care provided at out-of-network facilities or at in-network facilities by out-of-network providers. And then, out-of-network non-emergency care provided at in-network facilities without a patient's informed consent. Patients are also, as Matt mentioned, protected from surprise bills arising for air ambulance transports. And, that was a big one for us, just given the nature of, where strokes and most heart attacks takes place outside of, hospital settings. Patients just don't really have a say in where they would be transported, what their ambulance company was. So these protections are truly huge. And, I'll have to add too, under the law in these circumstances, patients will, not be responsible for cost sharing other than what they would have paid to an in-network provider. So equally important, providers will also be barred from holding patients liable for higher amounts. So, to kind of, I know my short answer turned into a long one, but yes, we are very pleased with these requirements.
And Josh, just to double check, right? It protects from balance billing from air ambulances, but not from ground ambulances. Is that right?
That's right, and that's kind of been reported on and seen as one of the so-called loopholes. But I think when policymakers were really approaching solutions, air ambulance is just a kind of a difficult. They're difficult to deal with. There's public ambulance companies, private, county-based, hospital-based, and it's just kind of the nest of all the different layers of how ground ambulance services are provided made it difficult for policymakers to address. But the law does require a report on air ambulance billing, ground ambulance billing. I'm not exactly sure when that's due, but that'll kind of inform future policy efforts around ground ambulance balance bills.
Very good, very good. And regulations came out that kind of clarified just the right-hand side, those requirements that have to do with surprise balance billing. Those came out on January 1st. If you're like me, many of you are flipping through that. One of the things that really comes through and emphasized in those rules is the protection of members. And there's a whole host of notices and education that needs to be put in front of the members in terms of telling them what their rights are under this act. And so I was very surprised and impressed by kind of the amount of education they were doing. Now, unfortunately, a lot of that's going to fall on the plans and the providers to provide those notices and those education. So it's going to be quite a lift for us for January 1st, but certainly the consumer is in top of mind when you're reading that in terms of the regulators. That's my point, right, Josh?
Well, I'd like to jump in on that. I think part of with informing as someone who's on the member side, right, who would be informed by their own company. I admittedly, when there are notices in the envelope, sometimes I read them, sometimes I don't. And sometimes when I do read them, I'm a little confused by what I've read, and I think that, if providers and payers could take it a step further and make sure that it's simple and not intimidating and, too jargony. My mother, she lives with me, she gets a lot of healthcare. And oftentimes she's like, what does this mean? And I'm like, I have to read this and figure it out. So I think that's something also to keep in mind, that it should be simple enough and digestible enough for people to actually understand, what does this mean, overall. I've been surprised by ambulance billing before, like, oh my gosh, I'm gonna have another heart attack, So I think that's also important. That outreach is important, but also, in a way that makes sense to everyone. So I just wanted to jump in there. Sorry.
No, I think that's a great point, and that kind of brings us to the transparency end, because I think we all get the bills, the healthcare bills, and if you're like me, it's terrible. I just let them sit until they turn red, right? Because I figure, let them work it out before they get there, right? Mm-hmm. But I think what you'll see with the transparency requirements is really a kind of a sea change in getting the consumer involved in healthcare and pricing and how healthcare bills are made. So we'll talk about that in a sec. We'll just go through the transparency provisions high level. First, both hospitals and payers have to make machine readable files. These are not meant for consumers, but I got to tell you what, there's a lot of organizations, academic organizations, government organizations, commercial organizations. They're going to be scraping and looking at those machine readable files. These all have the pricing, all the negotiated rates for every item and service that you see in healthcare today. So there's a lot of data that's now being dumped out there. This is very similar to the interoperability rule with the clinical data. They're freeing the data with those transparency, with those machine readable files. Provider directories, insurance cards, an advanced explanation of benefits for all scheduled services, and a price transparency tool. So Josh, I'll turn to you again. Of those list of transparency provisions, which ones get you the most excited, or which ones get you give you the most nightmares?
I would say probably the one that gets it kind of might be a bit of both with this one. What gets me probably the most excited is the advanced EOB for scheduled services. One of our underlying principles when approaching surprise billing from the get-go was consumer-focused transparency. And that patients should be provided with timely, actionable, and easy to understand information, help them avoid using out-of-network services for non-emergent care. And I think this really hits the nail on the head there with that. But at the same time, I think I do worry about how this is actionable and how this actually happens. I think it's going to be a key part of patients having this information will be a key part of seeking consent when they do want to go out of network. In order to, consent, they need to be provided with this information ahead of time. So it's critical that, this information is accurate. The good faith estimate is as close to possible to what the actual price will be. But overall, I think, anecdotally from our patients, lived experience in mind, even those who are among the savviest, healthcare consumers can still face, incredible difficulty in navigating their care. And I think, the protections overall combined with the new transparency provisions, particularly the advanced explanation of benefit, go a long way in helping patients and consumers, just better understand what they're going to end up paying and if their net provider is in network, not in network. So overall, I think they're very helpful.
Good, very good. So maybe what we'll do, let's dive into the advanced explanation of benefits. And I'm going to ask the slide presenter to skip the next slide and go to the slide after that. And maybe we'll ground set here and talk about what's in this advanced explanation of benefits. And the way I think about it is, we all watch commercials, right, of cars, and we see a car we like, and across the commercial, it'll say starting at 32,000. Well, actually, the cars I'm looking at are starting at 21,000. But let's just say it's starting at 32,000. Well, that's great, right? But if you're actually in the market for a car and you're looking for a car, probably what you want to do is pick up your phone, right, and call the dealerships in your area and say, hey, I see that, this Mazda Miata is going for $32,000. What are you selling your Mazda Miata for? Well, depending on the dealership you call, they've got leather seats or they got a fancy radio, and you're maybe never going to find that 32,000, right? So the advanced explanation is that same kind of idea where you're getting from the provider, you might have a cost transparency tool, or you might have a guess about what a general procedure or item might cost in a hospital. But here's a way for a member, a patient, to get that information based specifically on the procedure you're going to get on the day you're going to get it. And so because of that, the No Surprises Act says that whenever a patient schedules a healthcare item or service, and right now, we'll see what regulations say, but right now the No Surprises Act says all providers and all items or services, out of network, in network, facility, complex procedures, family annual visits, it looks like it's very open right now. We'll see if the regulators will narrow that scope. But for all healthcare items or services that you schedule an appointment for, the provider must send a good faith estimate to your health plan about what that item or service is going to cost. And then your health plan has to turn around and send you, the member, an advanced explanation of what that cost is going to be based on what the provider said it's going to be, and also what your cost sharing will be based on where your deductibles are at that particular point in time, right? So you should really get, just like those phone calls to the dealerships, as a member, as a patient, you should really get exactly how much, not exactly how much, but maybe an estimate of how much this is expected to cost. So this sounds great, maybe from the member standpoint. This is a huge lift, as Josh said, for both providers and for health plans in terms of implementing, in terms of thinking it out, because this is just not how claims are done. This is just not how bills are done, medical bills are done in this day and age. So I'll just discuss some of the loopholes here, not loopholes, but some of the burdens here, right? First of all, providers, as you know, if you get to go to a procedure in a hospital, you often get multiple different bills from different sets of providers that were involved in that procedure. Under the No Surprises Act, at least how it's written now, the facility or the provider, that's the head provider, is required to pull all that information together into one good faith estimate and to send that to the health plan. They're also expected to send that within 1 day if you make the appointment within 2 weeks of that healthcare service. That's a very quick turnaround for a good faith estimate. How is the provider going to send that to the health plan? We don't know. Government hasn't said anything. Industry started conversations, but it's all based on maybe 3 or 4 paragraphs in this No Surprises Act. Then the health plan in turn has 1 day, if it's within 2 weeks of the service, to turn around and get that information to the member, either digitally, electronically, or by mail, depending on the member's choice, right? And again, this has not been decided. So and they have 3 days if it's beyond 2 weeks. So 3 days is a little better, but those are very quick turnarounds for doing really 2 transactions, provider to health plan to member, that don't exist right now. The last thing I'll say about this is the other thing that this is based on is a request from the member. So one, you schedule an appointment, it should be automatic that the provider sends the good faith estimate. Also, just like I said about the cars, you can pick up the phone and call 3 or 4 different facilities and say, how much would this procedure cost? And each one of those facilities is expected to send a good faith estimate, and you'll get the estimate to the member. So there's the view. Josh, what are your feelings on the advanced explanation of benefits? Like you said, pros and cons, looks great on paper, maybe.
Yes, it's the question of actualizing it. And I will say, January 1st, 2022 is not that far away. I mean, in the patient view, this will be critical to, again, empowering patients to know what they're going to pay ahead of time, and what their expected cost sharing is, what their insurer is picking up. Now, this hasn't been the case. You usually get your explanation of benefits after your services. A lot of patients end up thinking those are bills. But I think this will be critically helpful to just all consumers of healthcare in the country. It's just a matter of putting it into action.
Yeah, and we had some questions about whether fire would be involved in any of these requirements, whether there are any new HIPAA administrative transactions. Certainly, the industry is thinking about, and you can tell from what the government is saying, what the regulators are saying, that we should be thinking about how to use the 837 claim. How to use, do you do a pre-estimate? How to use maybe fire to organize things on the provider end and pulling together. So lots of questions out there. But I also know lots of health plans that are moving very quickly to put something up by January 1st. And maybe with that, we'll move to the next slide, which kind of gives us a hint about what's to come. So we've seen one regulation published in July that talked mostly about the reimbursement and about consumer protections. In August, and maybe as soon as a couple of weeks from now or next week, because so far the administration's been on time with this, this is going to be mostly on the IDR process, again, just with the out-of-network claims that fall into those claims that are protected from balanced billing by the No Surprises Act. So it's all on the right-hand side of the column through August. And then we may see, they said, an advanced explanation of benefit, at least on the provider side, before January. So maybe a little bit of regulations or clarity about what providers have to do. But that's really the month before. That's going to be the Christmas present before the January 1st effective date. Some more information on the price transparency tool. And then it's not till after actually the effective date that ID cards and provider directory regulations we can expect. And so some New Year's Eve presents on the eve of the effective date, some afterwards, but also the government expects what they said is a good faith attempt at meeting compliance with these requirements. And so, Josh, I don't know if you have any input on this. My feeling is that there'll probably be enforcement discretion and a little bit of easing by the regulators in terms of the advanced explanation of benefits, but we'll expect that on January 1st, all the No Surprises Act protections should be in place.
Yeah, no question about that. The protections will definitely be in place January 1st. I think there probably will be some, enforcement discretion around some other parts of the law. But I think, again, I go back to, that notice and consent piece, patients knowing what they're going to pay if they go out of network is critical to being able to, consent in an informed manner. So that's where it's like, it gets a little complicated, because if you, don't enforce that piece of it, or needing to provide a good faith estimate and the advanced EOB, patients may not be able to knowingly consent for out of network care.
Yeah.
But we are certainly weighing in on all of this, and certainly keeping our eyes peeled to the Federal Register.
Yeah, yeah, and remember that this is all within a number of interoperability requirements that have to be made over the next couple years. So there's a lot of work for healthcare entities. And with that, maybe I'll turn it over to Ruby to talk a little bit more about the health plan impacts.
Yeah, hey, thanks. I wanted to make a couple of comments on what you presented. I think it was so helpful that you and Josh, Matthew, grounded us in some of the rules. And one thing is there already some swagger documentation up for price transparency, not assuming you would use FHIR. The Da Vinci Group, HL7, other teams are already working to put a candidate together for FHIR to be voted on as a standard to support some of these regulations. Unfortunately, though, they're not expecting the vote to happen until after January 2022. So I think this sets the table for a complex world. And then you mentioned at the end that, oh, well, will there be any discretionary enforcement? I want to remind the audience that this is one of the few bipartisan issues out there. This was voted in or signed by a Republican president. It's been affirmed by the Democratic president because we see these regulations starting to come out. They didn't try to pull it back. They're not arguing it. They're taking it forward. So this is bipartisan. So this means that sitting and waiting with hope that something's going to change and you don't have to do anything, it's probably not super wise. So I really do feel like this one might stick. Do you want to comment on that before we move forward?
Ruby, I'll double down on that exactly, especially given the news this week. Last week, was it this week or last week? Holy cow, the weeks. But the administration's already come up. CMS has come up with another proposed rule and that proposed rule ups the enforcement penalties for the hospitals that are not complying with their transparency requirements that started in January. That's up to $2 million a year if they don't comply. So if you think that the politicians, the regulators are coming down hard on the hospitals, you can only imagine what they're going to do to health plans and insurance companies. So that shows a definite seriousness from the point of view of the administration. And like you said, both sides of the aisle, definite seriousness.
Yeah, thanks for that. Josh, did you want to add anything?
And I'll just add, in the president's recent executive order on promoting competition in the American economy, I think it came out a couple of weeks ago. They also reaffirmed their commitment to implementing the No Surprises Act. So just kind of adding your point that, they're definitely not shying away for this and they are all in.
So surprise, we actually have bipartisan agreement. so
that's a good part.
So to move ahead a little bit, I'm going to represent Eric today because he sends his regrets he can't make it. So one slide, please, forward. Eric is one of our customers. We've been working together on the interoperability rule. I love this statement. Eric did this. I did not do these slides for Eric. Eric came up with this. And it's like, you guys have a plan and you're really missing out hearing from a really thoughtful gentleman about the challenges of compliance and how projects don't always go the way you thought they would. And so if you could go one more slide forward. Eric offers all of you some from the trenches points of view, a roadmap that connects the mandates. At Axway, we also believe that there are reusable bits and pieces out of the interoperability rule, price transparency, no surprises, and you need to think about these things as interlocking or at least building on each other. I've already seen a bunch of questions on commentary around provider directory. Well, the first provider directory was part of the interoperability rule, but now we see that being used again in these subsequent regulatory requirements. So we've got to start thinking about things as connected and part of a longer term program. I think his statement about collaboration between business and technology, you can't just throw these requirements over the fence to your technology team and walk away. It's going to change how you do business. And I'll come back to some ways that might happen. But you could already hear from listening to Matthew and Josh that just the collaboration and the work together is going to be different. Hospitals are going to have to talk to their subcontractors in ways that they haven't automated historically. So a lot of questions that can't be solved simply by a technology team. One thing that I also double down on with Eric is, like, are you just checking the box, or do you see this as an opportunity to transform your organization? Do you see this as an opportunity to change? I think you really have to spend a few minutes with yourself and your business leaders, yourself being a technologist, that's always my point of view, a technologist, to sit down and really talk about that, because it changes how you're going to budget, how you're going to staff, and how you might go about this. So there's a lot of challenges about build versus buy. As a vendor, you can certainly take what I say with a grain of salt, but I have to tell you that there's people who say you can buy everything turnkey from them. There are people who say best of breed. It's very unlikely that any one technology firm can deliver everything you need across the entire horizon from Interoperability Rule to No Surprises Act. So think carefully about your current partners and where your gaps are and where you want to add people in. And, you know, as Matthew noted, some of the new rules apply to everyone, not just certain groups. So are you going to actually ask your members or your patients, oh, well, who are you? And if you're not so-and-so, you don't get this. So you need to think about the patient experience and the member experience and the developer experience. And delivering a brilliant experience is key to your success. You can't just phone in your front door. The front door is going to be their first view of your organization. That advanced explanation of benefits may be the first thing they learn about your company or about your hospital, about your facility or your membership plan. If that's not done well, then what are you setting them up for in terms of experience? And you know, as Josh representing the consumers here, you know, you the patient and the member are making really tough decisions, sometimes for your family members. The ability to understand all of this is something we don't have in the US. And I want to remind the audience that the majority of bankruptcies in the US are caused by healthcare bills. So this is not a trivial problem for many, many people in the US. They don't know in advance. They don't know how to solve this. This is super important stuff. So, you know, you've got to think about the experience. And then I agree also with Eric that data is going to be a curse in this entire process, because we don't have data in HL7. We don't have data exposed and wrapped with APIs. We don't have the data from our partners that we need. So we've got a lot of data challenges to actually serve the technology up to do this. So with the next slide, I'm going to transition into some technology pitfalls. So please, as you read this, think about these as pitfalls, not about solutions. So these are the challenges you might experience. So we've seen this, that healthcare partners, their solution may change. So you talk to your partner. You could imagine your partner being a pharmacy benefit manager. It could be a vendor. It could be a cloud provider. And you go to your leadership and say, I'm going to do this project for this cost because partner A says they're going to do this for us. But then partner A realizes how hard it is, how expensive it is, or doesn't really deliver the full solution. You are in midstream and things change on you. This is happening in real life, and I expect it to happen even more as we move towards price transparency and No Surprises Act. You cannot just buy a piece of technology. All of these rules, from Interoperability Rule to No Surprises Act, they affect the people and process. Your call centers need to be aware of this. Your compliance officers need to weigh in on how you expose fire. You have to have ability for people to register issues. So don't forget the people and process. And Now we have third-party developers in the mix, which we haven't had before. So how does a third-party developer identify themselves to your organization? So lots and lots of new things to think about that require people and process, not just technology. And we all have tended to do authentication behind the front door. We didn't try to authenticate across enterprises. We didn't try to authenticate a third party representing another person. It's challenging, and things we thought were working well may not work across all these new constituencies. And authentication is essential to protect ourselves from the ransomware bad actors that we see out there every single day that are worrying all of us. We've talked about data integration. FHIR integration is really important, but if your data source is not in FHIR, like, make sure you add more time to your schedule. There's a lot of varying data sources out there. A lot of the health plans originally chose a facade or a repository. The problem with healthcare, let me explain facade and repository. So facade is, I'm going to leave all my data sources where they are, and I'm going to orchestrate transforming claims data, pricing data into HL7 FHIR resources on the fly. And I'm going to do that while someone's on the other end of a process or waiting for me. The repository says, I'm not so sure I can do that on the fly. I'm going to make a copy of data into an HL7 representation that will naturally speak FHIR, and will allow me to respond in real time using this repository. Well, because we have so much data in healthcare, I think those who are using repository are going to have to think about that some. It could get expensive. So make sure you think through your data integration problem from soup to nuts, because there's a lot involved in it. At Axway, and 1A knows this because I say this all the time, this is not just another regulatory compliance project. You are transforming your company. You are changing everything. It's transformation from portal to payment. We've never done projects that affected that much of our business at one time. So from the member portal, the patient portal, the developer portal, all the way to the bill, things are changing. So this is huge. This is not like get a team together, assign a project manager, here's the requirements, go away, leave me alone, it'll all take care of itself. Now it's going to touch a lot of things. And that means, of course, that you can't test at the end of the project. I also want to remind people architecture matters. Reuse is going to be the only way to reduce the cost of compliance. It's going to be the only way to speed the delivery of the projects. As Matthew showed, the timelines are tight, and we still have more work to do on the interoperability rule. We have the payer-to-payer rule coming, and we've got prior auth coming, and some of those are foundational to getting the advanced explanation of benefits to work because there's similarities. And if you do this in FHIR, maybe you could reuse something. So a lot of thinking there. We also are building the plane while we're flying it. So the versions of FHIR are going to change, and that means that some of your partners might use version 3, and some will go and get version 4, and some will go out and get the candidate modules and want to start work with you even before it's been voted on. So how are you going to handle versioning? And then resilience. One of the hardest things, and Eric and I have talked about that through our teams, is how do we predict peak load processing? We don't know how many people are going to download their data. We don't know how many people are going to ask for an explanation of benefits at the same time. We don't know if something breaks, how many things are going to be stuck mid-process in the breakage. So we've got to think a lot, not just about checking the box, oh, I got it, the portal, it's turned on, I can walk away. No, I have to think about my load and how many things are going to happen at once and how my partners are performing and can they meet the requirement to respond before I time out and give up on them. So across the board, there's pitfalls that I believe if we think about now and we think about with reuse and we think about with experts like Matthew and Josh contributing to ideas and thinking about the experience we want to deliver, the reputation we want to have, the data we want to serve up, and we do that in advance, we've got a good shot at making our way through this challenging journey. That's my speech, 1A. Thank you. 1A, you're on
Thank you.
mute.
Yes, sorry. It's a Zoom day. Sorry. I want to thank everybody. That was really, really great. Great way to kick off this discussion. We have a lot of questions here, and I want to make sure that we get to them. So one of the questions I see here, or Josh, like, already answered it. Does the act apply to Medicare and Medicaid as well? And that was one I was thinking about too, because thinking about some of our more vulnerable healthcare patients and what this means for like low income patients who may not necessarily have these options. Josh, does this rule apply? And what do you think would be, what do you think are like the impacts on Medicare and Medicaid patients?
So just generally, because balanced billing is prohibited under Medicare and Medicaid, these provisions are pretty much not so relevant for patients covered by Medicare and Medicaid. And like particularly, like for instance, like disclosures don't need to be provided to those patients with those sources of coverage. So I would say it doesn't apply to Medicare and Medicaid patients.
Okay, thank you. Next question. We have a lot of questions going through here. Oh, here's one that just popped up. Jorge, you're lucky. How does this affect federal programs like VA and DOD?
And likewise does not apply to folks covered under VA, DOD. Really, it's only those covered by commercial insurance plans.
Okay. And what are the obligations of providers to send advanced explanation of benefits data to health plans? And what are the penalties for the failure to do so?
So the obligation is that, at least how it's written now, we've got regulations forthcoming, but that providers, every time an appointment is scheduled, a good faith estimate has to be, well, two things. First, you have to ask who your payer is, ask the patient who the payer is. If it is a commercial payer, then you have to send a good faith estimate to the payer of how much you think the items and services will cost, an estimate of that, and how much any related items or services or related providers that may be used, how much they will cost. And that is on the providers, specifically in the No Surprises Act. The penalty, and I might need Josh for this, I think it's $10,000, $10,000, Josh, or $100,000?
$10,000. But it's not clear if that is just a violation of the balanced billing requirements, or if that's a violation of any part of the law. And I suspect future regulations future rules will clarify that.
And I'll just jump in. There's another question related to the advanced explanation of benefits we'll hit. There's a question, well, why not just use your price transparency tool to use that as, and I do want to call this out, because at least how it's written, this is much different from a price transparency tool. And what makes it very, very different is the price transparency tool is information that the health plan has internally that's a lookup, or the hospital has internally that's a lookup. They're both required to have that. But this needs that good faith estimate about that particular scheduled appointment, about the cost sharing at the time of the notice, what the hit is on your deductible and everything else. So it needs that provider estimate as part of the advanced explanation. There's no such thing as a health plan sending an advanced explanation of benefits without that good faith estimate as one of the primary data points. And there's where we get to what Ruby's talking about, where you got to coordinate with providers, and plans have to coordinate together to figure this out.
Right. So let me talk about that from my personal experience to kind of bring it home. So my husband had back surgery not so long ago, and we were trying to figure out what our out-of-pocket was going to be. And, I never did. I called the hospital up. They couldn't answer my question at all. The doctor's office said, oh, we can tell you what we're going to charge. So the doctor's office wrote down the DRG codes for me, right? Then I took those and I called the health plan, and the health plan acted like they'd never had anyone who ever asked them this question before. And they gave me also some standard stuff. So this is the difference between price transparency and an explanation of benefits. So price transparency, you have your 250 odd procedures. You're going to post those in English terms. A lot of people are envisioning that almost like a grid or a spreadsheet. That's not customized to me. That doesn't mean that I know that which one of those would apply to my husband, right? With this, they would take the exact procedure they want to do for my husband, and they would write the DRG codes, and I'm translating, technical stuff into people stuff like it was paper, mail that off to the health plan. The health plan then is going to assign their reimbursement rates for that hospital provider combination to this and send me back a copy and a copy to the doctor's office. What Matthew was alluding to is like if the hospital has contract anesthesiologist, how is that going to get added in? And you can also see where a prior auth fire is a lot like the request I'm sending with this explanation of benefits off to the health plan. It's the same kind of data elements. And you can see there's a lot of questions about provider directory. Well, why wouldn't you reuse your provider directory to get a list of whether these people are in network or out of network? Why would you build a whole new tool for the No Surprises Act or price transparency to look up the provider to see if they're in network or not? Why wouldn't you use what's in your provider directory? So you can see how reuse might kind of build here.
Right.
And we can take, if we could, let's take Ruby's example there and see what this might look like 5 years down, when let's just assume that we get things together and there is an advanced explanation of benefits and every time you schedule, you get something like this. First, from the consumer standpoint, maybe Josh will talk more about this, right? Imagine that's all now on your phone, where you're planning a back surgery and you look on the price transparency tool, which pops up on your phone, which also has your clinical data, right? Because we've got the interoperability. And it asks you if you just have to click a box next to each one of the facilities nearby that gives it. And automatically, they're going to shoot a request off to those facilities to send you an advanced explanation of benefits, which doesn't come through the mail. It pops up in your text, and you'll be immediately able to compare, right? So there's the consumer part. Think about the health plan part. This is the first transaction where you're getting in front of a member, Ruby, while she's thinking about her husband going through something, before she goes for a very expensive procedure. Think about the messages that you can give Ruby. You'll be able to give the good faith estimate, but you'll also be able to do steerage. You'll be able to say, well, here's a quality provider over here. You'll be able to say, hey, next year, if you do this under your silver, come with our silver plan, you get a bit like you are getting in front of a member and helping them make the choice. Provider is the same thing. Here's where you really have to think about how you're going to bill that consumer, and also how you're going to sell yourself to that consumer. Because if you're coming at a higher price tag than you think the facility across the street is going to get, then you're going to want to sell your quality, your performance metrics. You're going to want to sell this. So I think it's going to change, thinking strategically, but also thinking about how it's going to change the way we think about healthcare. There's a lot going on in this little advanced explanation of benefits.
I think, but with that example, I think that there's also room, and I'm not going to assume that anybody's unscrupulous, but also it creates competition between the providers, right? Because now consumers have a choice. And what I could see potentially happen, someone actually asked this question about, is like the accuracy of your advanced explanation of benefits, and like how close does that good faith estimate really have to be? Is it a range? Because we all hope for like the lower range, right? And then sometimes we could still get surprised by being like on the higher range. So I think that, hopefully there are some protections in place for consumers as well, so that because there's still opportunity to be blindsided. Thinking about Ruby's example, I'm thinking about my mom again. She just got a surprise dental bill for, I think it was like $5,000. And I was like, what? It's like, what did they do to your teeth? Like, what happened? And it was very simple. It was out of network, and she didn't know, she didn't realize they were out of network. They kind of did thanks for visiting us, check out, go see the doctor now, just kind of rushed her through this process, and didn't really take the time for her to understand her benefits or what was in network versus out of network, and all these wonderful things that go into it. So I see with this, with being forced to provide, or required, I shouldn't say the word forced, but being required to provide this good faith estimate up front, and being required to take this extra step to provide this advanced explanation of benefits, and then removing that and going right to your phone. There's a lot of transparency that's definitely involved in that. And there has to be like a lot of coordination, and providers and payers, and everybody has to be on board with that, and I can see where the market is not going to be competitive, and then it's no longer, you just take what we're going to give you. You now can choose to take what we're going to provide, and you can choose, choose to or not to, you know. And so I see the healthcare landscape definitely changing. This is a huge, huge shift in how we, not only how we receive care, but how we choose our care, and now actually feeling like we have a choice. And I say we because I'm representing the consumer here. I know you're here too, Josh, but I'm
and I was just going to dive in there because you mentioned, like, you know, some sort of protections around, like, if that good faith estimate is, you know, completely off base. You know, that's something we're certainly going to be weighing in with regulators. But I will say for uninsured individuals, there is a separate dispute resolution process where, you know, if you get your good faith estimate and then, you know, later you get your care and your billed amount is significantly higher than the good faith estimate, you can actually challenge that. But that is, it's really just for uninsured patients.
Right.
I need to do some more digging and see what it is for everyone else, but that's something we will certainly be weighing on to ensure, you know, good faith is actually good faith and that estimate is as accurate as possible.
And on that, we have a good question here, actually. And the question is, do all providers have to send that, or is it just for those who are out of network?
So it's definitely in network and out of network.
Okay.
And right now, the way it's written, it's all providers. But you can tell it's different for in network and out of network because actually the good faith estimate, the advanced explanation of benefits has slight different data that's necessary, whether it's in network or out of network. So definitely a broader swath than just the out of network. And then we'll see if regulators narrow the scope. But right now it reads everybody from your family doctor to with an annual physical that you know the price already maybe, to very complex surgeries.
So does this mean like at the time of appointment, like that's the time where they need to disclose whether or not they're in network or out of network? Or if I'm not mistaken, the slide was like 1 to 3 days. If the appointment was made 2 weeks prior, right, then they have, I think, 1 to 3 days to get that. So at the time that someone makes an appointment, it's, hello, Mr. Albright, thanks for calling. By the way, we need to tell you that we're out of network and there's a good faith estimate coming your way. Is that how that conversation's gonna go? Is that the intention?
So not exactly, because there's no requirement that the provider tell the member anything.
Okay.
The provider has to send it to the health plan, right? Except in the case of those other set of claims where it'd be a surprise. So, right, in those cases, you definitely have to be upfront, you're out of network, et cetera, right? But they do have to tell the health plan in the advanced explanation of benefits whether they're in or out of network, and of course the plan will double check that.
So this is a good question.
Yeah.
I'm sorry to talk over you, Juana.
No,
This is a good question I have. It's my understanding, so Josh and Matthew, you correct me, is that this is one of the reasons why provider directory is now really important. So let's say, Juana, that I did your advanced explanation of benefits on Monday using a provider directory that's out of date. You have your surgery a week later, and that provider's not in network because we had a contract dispute and I dropped them and I didn't bother to update the provider directory. So now you get a real bill that's 5 or 10 times more than you expected. I do believe the law says I have to honor what I originally said that you were in network. Is that right?
Yes, that's correct. And I think it's kind of seen as an incentive to you know, ensure that those directories are up to date. You know, patients will only have to pay in-network cost sharing if they, you know, are able to document that they relied on an out-of-date directory to seek what they thought was in-network care.
And there's the requirements. There's another question, right, about what are the provider directory requirements in the No Surprises Act. There's provider directory requirements for both providers. They have to make sure they update their information for the health plans during certain times. Those are requirements. And then the health plans now have to do what we've seen in many state laws for fully insured, where they have to verify and make sure their data is updated every 3 months. And also have a turnaround day of, I think it's 2 business days where they have to be able to update any new information coming out. Very tough turnaround days to hit for health plans. And this doubles the amount of health plans basically in this country that have to keep their directories up. So that's going to be a lot more verification of data by providers who are now going to be dealing with 2x, 3 times the amount of plans. They're going to be like, hey, are you sure your information is correct? And then there's a lot of health plans out there who haven't had to be able to keep those directories up, data that will now have to.
I imagine these smaller health plans are going to really be, there's going to be an effect on the smaller health plans and like on the smaller providers as well. And in terms of like how they coordinate their care and, you know, what this is going to look like. So we have 2 minutes. I want to get everybody's quick closing thoughts on exactly that. What is this? Where are we going? What does this look like in I can't even say 5 years. Let's say 1 year. 1 year after this is live. Like what is this? What's the impact on healthcare? Good, bad? What should we be worried about? Can we sleep now? I'll let Matthew go. Yep.
Well, I'll say in 1 year, I think there'll still be a lot of dust. I think there'll be a lot of question about who's compliant. I think there's going to be a lot of contentiousness too between plans and providers off the shoot, because figuring out when the state requirements apply and the No Surprises Act applies. That's going to get kind of confusing. When is a thing an emergency? Very broad definition of emergency in the No Surprises Act, which maybe not everybody's going to be able to figure out. So I think there's going to be a lot of contentiousness. We're not going to really see how the reimbursement, at least between a payer and provider, is settling out in a year. But I do think in 5 years with the transparency stuff and the No Surprises stuff, I think we're going to have a consumer-driven healthcare, and I think it's going to be a lot like buying a car. There's a lot of non-healthcare people going to jump into this space who know how to use data and know how to move people through that data and monetize it. The Googles, the Facebooks, the Amazons, they're going to be jumping into this space because this is going to be members.
There we go. Josh, what do you have to say?
I was just going to say, I mean, I think, from the get-go, obviously, patients are going to be protected from surprise bills. I think other aspects of the law, maybe some kinks and in time and adjustment needed to comply. But, overall, I think the view, as all of us are healthcare consumers at some point in our lives, I mean, you should think of it as, you are protected now. You don't have to worry, you're going in for in-network surgery. You're not going to get hit by a separate bill for an anesthesiologist anymore and out-of-network rate. So just know, I think the big thing for us is patients are protected and empowered through these additional price transparency provisions.
Empowerment. All right, Ruby, I'll let you close it out.
Yeah, well, I'll double down on my little tagline of you're going to transform from portal to payment. So everything's going to get touched in the next 5 years. 1 year in, we're going to know what we don't know now, and we're going to wish we had replanned our projects. So I really advise you to put a strategic plan together, build in some extra money, and try to think about reuse. And then the last little bit is I double down with Matthew. There's going to be some disruption. Some VC-based hotshot coder is going to come in here and do something that's going to be very different. So I think we're in for a fun ride.
Well, if there's any VC people listening, you just got your next idea.
Send us money.
All right, I want to thank our panelists for a great discussion. I wish we had more time because people are getting into me and all these questions, and I apologize for not getting to everybody's question, but I do hope that everybody enjoyed the presentation, enjoyed the panelists, and learned a lot. And pay attention to these regulations. They're out there and they're coming fast. They are just coming very, very fast, and they'll give you whiplash if you're not paying attention. Again, thank you all for joining. Thank you to the audience for joining, and have a wonderful rest of your Wednesday, wherever you are. Thank you. Take care.
Thanks.
Bye.
Thanks, everyone.